We're going to go ahead and get started. So good afternoon, everyone. Welcome to the 2021 Heartland National TB Center and the National TB Nurses Coalition webcast. Today's title is COVID-19 and TB, Diagnostic Delays and Unrecognized Risk for Progression of LTBI to TB Disease. If you have any questions regarding the content in today's presentation, please enter those questions in the Q&A pod, and they will be answered at the end of the webcast. We are recording the webcast, and it will be made available after the end of the session, or more within maybe a week after this session. At the conclusion of today's program, we will email the link to a brief evaluation. Your feedback is greatly appreciated. Please welcome our speakers, Catalina Navarro and Marybel Monreal, nurse consultants for Heartland National TB Center, along with guest speaker Jeanne Salinas, TB Program Manager for Hidalgo County Health and Human Services, who oversees the TB program with collaboration and guidance from Texas Department of State Health Services and Region 11. Welcome, ladies.
Thank you, Roshanda. This is Catalina. We are so happy just seeing all the people that joined today. Thank you for attending this webinar. By now, all of us, the whole world, have been hearing about COVID for maybe 20 months, almost 2 years. And we know that we are going to continue hearing about this for many, many more years. This pandemic hasn't finished, and there is still too much to investigate and to learn. In regards of the potential impact of COVID-19 on the TB care, we haven't heard too much. But as you can see on the screen, we have two main topics to present today. First one is going to be the obvious delayed TB diagnosis due to COVID-19. We are going to present a case study with all the challenges, lessons learned, and some teaching points to take home. The second part of this webinar, we will be talking about something relatively new, the emerging evidence that suggests that COVID-19 could be an unrecognized risk factor for the reactivation of latent TB to TB disease. But let me start with the fact. This is a fact. There is evident delay of TB diagnosis due to COVID-19 during this pandemic. We all know that the most important components of TB care are early diagnosis and early and adequate treatment. Delay in TB diagnosis and delay in initiation of treatment is going to result in more extensive disease, more complications, and it is also associated with poor outcomes. Dozens or maybe hundreds of studies around the world confirm that delay of the TB diagnosis during this pandemic. We have studies from USA, China, Italy, all over the world. Cases of delayed diagnosis and TB have been reported. These are some of the headlines that I just found, and probably you on your own health department, on your clinics, you have seen several cases of complicated TB. Maybe you have patients now with severe TB, advanced disease, maybe with disseminated TB, TB meningitis. Maybe you have seen an increase in TB deaths. And if we pay attention, maybe you are going to find the common denominator of delay in diagnosis due to COVID. But what are the factors that led to delay in TB diagnosis? These studies that I show, they said that some of the factors are that patients were afraid of seeking care because of fear to contract COVID. Other factor is that the facilities were locked down. The patients didn't have a place to be screened or to be treated for TB. TB staff was moved to serve the COVID pandemic. And the last factor is because most of the time, healthcare workers, clinicians, nurses were just thinking in COVID. COVID was the focus, and maybe we missed TB while focusing COVID. So what are the consequences of this delay? Oh, sorry. This delay in TB diagnosis affected so bad the improvement that have been made in the fight of TB elimination. 12 months of COVID-19 eliminated 12 years of progress in the global fight against TB. This was the headline of TB Day, March 24, 2021. Prior 2020, the world was making good progress against TB. COVID pandemic just disturbed this good path and set back the fight against TB. This is alarming, and there is a need for recovery of TB responses. TB organizations already worldwide are working in recommendations for prevention and care about these two diseases. Now I want to invite you to listen to Jeanne Salinas. She's one of the heroes at the local health department close to the border with Mexico. She's going to present a case study that illustrates the challenges, lessons learned due to delayed TB diagnosis because of COVID. Just please welcome Jeanne Salinas.
Thank you, Catalina. Hi, good afternoon, everyone. My name is Jeanne Salinas, and I will be presenting today delayed TB diagnosis due to COVID-19. So before I get started, I have the following to disclose: that I have no conflict of interest and have no relevant financial relationship with any commercial companies pertaining to this educational activity. So the objectives I will be hopefully discussing today will be review a TB case study from Hidalgo County where diagnosis was delayed. Also review challenges during the patient's TB treatment, explain how we overcame the challenges, and share talking points and lessons learned. So just a little bit about Hidalgo for context. This is Hidalgo County, and right down here, you'll see the state of Texas, and we're way down here at the tip by the Mexico-Texas border. It is located by the Texas-Mexico border along the Rio Grande River. It is the 8th most populated county in Texas with a recorded population of 881,525 residents. However, we do have a very fluid border and an influx of immigrants. This number continuously changes to be able to record a real-time population, and is way over 1 million. So TB case rate decline. I think this is something that everybody has been affected by with COVID. So here's a graph where we will see from the years 2016 to 2020, and in comparison from US to Texas to Hidalgo County. So Hidalgo County is the line in yellow. And so from 2016, you'll see more or less up and down, but more or less steady. On average, Hidalgo County does have anywhere between 60 to 80 cases per year. And then you'll see 2020, a huge decline, as well as you've seen like in Texas and in the US, even though they do have lower numbers, but you do see that there is that significant decline. So TB cases dropped dramatically during the COVID-19 pandemic due to being highly underreported. When it was reported, the diagnosis was often delayed and patients presented with advanced TB disease. So the case presentation that I'll be presenting today is a 24-year-old female born in Mexico. She had symptoms since February of 2020, which was cough, night sweats, hemoptysis, decreased appetite, nausea, shortness of breath, fatigue, weight loss, chills, and fever. So she basically had all the symptoms. When she presented herself to our clinic on 8/6/2020, she had tachycardia, she was in the 130s, shortness of breath, and fever of 102.5. So the staff at the clinic did do a COVID-19 test, a rapid test, which did show that it was negative, as well as one was conducted also at the hospital, which also showed that it was negative. Another repeat one was done on 9/21 post her hospitalization. And so she remained COVID negative throughout the whole time. So from the beginning of the suspicion of tuberculosis to when she was discharged from the hospital. Her quantiferin gold was indeterminate on 8/13/20. A T-spot was collected, which showed was negative on 9/9/2020. There was a PCR that showed that was positive on 8/9/2020, along with a chest X-ray that showed abnormal cavitary with a miliary pattern, which was also noted on a CT on 10/23/2020. So her predominant sites were pulmonary and miliary TB. She had AFB sputum smears that were collected. There were greater than 10 per field, and these were collected on 8/8, 8/9, 8/10. So once we got those specimen results, the hospital initiated treatment, and RIPE was initiated on 8/12/2020. So just to kind of recap and kind of go over a little bit more in depth, as health and social risk factors that were found was the significant weight loss, which was that of 45 pounds. Again, this patient is foreign born. She entered the US on 6/15/2020. She was undocumented, low income with no health insurance. She was also a homemaker with 3 children. Her youngest child delivered late in 2018. So, as mothers, it's common for mothers to put their children first and health last. So that was one of the biggest social risk factors that we also highlighted onto this. Her level of education was junior high. So also educating the patient. Intolerance to TB medication regimen as evidence to drug stop. So she did stop her regimen on 9/9, and then a restart was done on 9/23. So there was a risk for developing drug resistance in order for us to go ahead and get her on a right regimen and make sure that she was, of course, treated correctly. And the reason why there was drug starts and stop was because of an increase of liver enzymes and also a decrease of platelets. So this was noted shortly after RIPE was RIPE was started. And you'll see the fluctuating lab results, which are noted on the following slide. So here you'll see her LFTs and platelet trend. So originally on 8/10/2020, her platelets were at 391 with ALT at 17, AST at 26. And so as you can see, those are going up and down throughout the course of treatment. So treatment was started around here this time on 8/12. And so you'll see that those numbers are going up and down. And so when the patient was discharged from the hospital and labs were collected at the health department on 9/8, clinic reported the results were AST was at 21, ALT at 18, and platelets significantly dropped at 22. So there was a huge drop from 107 on 9/2 to 9/8 of 22. So this is her images. Not only did the patient have unstable abnormal labs during her initial diagnosis, but extensive TB is seen on the chest X-ray. So this X-ray was her first image, which was on 8/6/2020, which reported with bilateral interstitial and alveolar infiltrates with right perihilar and lower lobe consolidations. Seen on her CT on 8/12, this one was reported with right upper lobe lung consolidation with multiple central cavitary lesion. So as you can note right there was a huge cavitation. Then on 10/23, there was a repeat CT of the chest, which continued to show extensive TB disease. Report noted diffuse miliary disease has substantially improved, but the cavitary mass in the left has become newly apparent. So I use these images so you can really note and see that miliary pattern, even though you really can't see on the left-hand side that cavitation that was originally seen. If you see more closely through the slides on the CT, you're able to note that cavitation. So just kind of to reflect back, this is a timeline of events. So the onset of symptoms were since February. So this is where we start off with our patient. So since February of 2020, she had started with her symptomology. Patient with advanced pulmonary tuberculosis complicated by delayed diagnosis during COVID-19 pandemic, and with fear of seeing a doctor due to her undocumented status until she self-reported to our clinic severely ill. So then she arrived at our health department on 8/6, which then she was transported out via ambulance to a hospital on 8/6. So at this point, she was there at the hospital where specimens were collected. These specimens were collected on 8/8, 8/9, 8/10, along with a QFT that was also collected. So once they got those smear results received, RIPE was initiated on 8/12, and that continued until 8/23 when the medications were held due to elevated liver enzymes. And then eventually eventually at her with extensive disease, which was a challenge to establish a stable and safe treatment. Treatment interruptions due to elevated liver enzymes and low platelets result in Heartland consults on 9/10 and Texas Center for Infectious Disease admission on 9/22. So when she got there to TCID, she started treatment on 9/23. So our first challenge. So our first challenge was the hospital adamant on COVID-19 diagnosis over tuberculosis. So on 8/6/2020, patient had a negative COVID-19 result from a rapid test at health department, yet doctor at hospital stated patient had full-blown COVID-19. Hospital note stated acute respiratory disease due to COVID-19 virus. And this is even with the health department referral on hand that was issued to the patient. That way she could give it to the staff when she was received at the hospital. And not only that, we communicated also as well with the infection control nurses. This resulted on SPIDA collections not initially done despite the health department's recommendation for TB workup. So again, the referral was given, SPIDA was held off. They were waiting for that COVID-19 test, and then eventually the labs were collected. Other recommendations that we also gave upon with a referral was if they could also collect AFB blood cultures to rule out extensive disease, which were not done. And on 8/12, a CT chest was recommended to rule out miliary TB, which was done, along with the start of right treatment after receiving positive AFB smears collected from 8/8, 8/9, and 8/10. So how do we overcome challenge number one? What we did is we provide support and guidance to hospital infection control staff to ensure that they have informed decisions after looking at the whole picture. Reached out to the network of nurses that has been built throughout the years of working together, utilizing your contacts that advocate for the patient to receive the appropriate services. So it's always good to establish a good rapport and reach out routinely to our counterparts in the hospital facilities, why become a beneficial tool when advocating for patients together. So always sharing that information, even if it's just like on a quarterly basis, maybe mid-year or once a year, at least saying hello and introducing yourself and just keeping that relationship alive. Challenge number two. So challenge number two is patient TB treatment management issues due to complications and liver toxicity. And also as well, patient fearful of leaving to TCID without family and worried about undocumented status. So reason why the patient was so fearful is that Hidalgo County, again, like you guys saw in the image, is where we're located. So Hidalgo County is located 4 hours away from TCID. And in order to get there, Border Patrol checkpoint must be crossed. Our procedure is to inform and request checkpoint clearance from Border Patrol once the patient has been accepted for TCID admission. We coordinate with Border Patrol staff to initiate clearance process and advocate for the patient's need to be admitted into TCID and receive the necessary health and treatment against the airborne communicable disease. So just think, put yourself in the patient's shoes. Just think the patient is caught in a situation for them to make a fearful decision to risk possible deportation or have their health worsen or even death. So how do we overcome this challenge? So consult with TCID in a timely manner to ensure patient receives the appropriate treatment with minimal interruptions. Educate patient on the benefits of being admitted to TCID in order to gain back her health and be reunited with family. Ensure the patient is aware of the health department's role to test for, treat, and prevent TB, regardless of citizen status. So that's something that we stand strongly behind. That's like one of the first things that we establish amongst our patients, our contacts, letting them know that what is important is their health. Citizenship status is not something that we collect that information, but their health is the important part, and that is our goal. So managing highly sensitive subjects such as citizenship or undocumented status takes education, compassion, empathy, transparency, and honesty when explaining interlocal procedures and managing these clients, and get them the higher level of care needed to achieve an effective regimen and cure them from TB. So some talking points and lessons learned. So education is key to helping patients understand the importance of treatment adherence. Education also builds trust between patient and clinic staff that strengthens rapport and ensures positive outcomes. Building a network among local hospitals and clinic staff it helps keep them informed and involved with TB treatment and prevention. So we need to remember that we're all on the same team trying to restore the patient's health. And so here's my final slide. So just to remember, find, treat, cure TB disease, test, and treat for latent TB infection. And I'd like to say special thanks to Heartland, Texas Center for Infectious Disease, Hidalgo County Health Department, pulmonary clinic staff, and the case manager, Elizabeth Reese. Thank you.
Thank you, Jeannie, for this excellent case. I hope you will have gained an insight into the challenges of delayed TB diagnosis due to COVID. Now for the second part. For the second part of the webinar, you are going to see more questions than answers. The first question is, could COVID-19 trigger TB disease? Are you now finding patients with TB in your own clinics who have had COVID-19? Are your patients with other comorbidities like diabetes or kidney disease who get COVID more likely to develop TB disease? More questions. What if COVID-19 is a clinical condition that increases the risk of progression from latent TB to TB disease? And you can start thinking, are there studies already answering these questions? Is there any evidence of TB cases after COVID? These are all questions being presented in ongoing research all over the world. There is still too much to research. However, I found something interesting about COVID and immunity. What is new in COVID-19 studies regarding immunity? I found several articles talking about immunity, and this study from Frontiers in Immunology shows that T cells, CD4 and CD8 cells are reduced significantly in COVID-19 patients, especially those patients who have been in ICU with severe COVID. We all know that the T cells, CD4, CD8, TNF-alpha, and other proteins play an important role in immunity. Additional studies have found that comparable with HIV, listen to this, comparable with HIV, COVID can cause an weakening of the immune system. So this is something alarming. Another studies that maybe you have heard are talking about something called cytokine storm. Under normal circumstances, these cytokines, that they are small proteins, help our immune system to respond and take care of infectious. However, on the cytokine storm, there is a huge and overwhelming immune response that can cause serious problems, and it can result in a short circuit of the immune system. And it also causes severe lung damage. And this is well-known study, and COVID-19 is causing all these problems with the organs failure, and most of the time is because of the cytokine storm. This is a problem because sometimes this body inflammatory response can get out of control, causing more harm than good. I am afraid that these are not good news for the fight of TB. But why? What has to be immunity with TB? We all know that LTBI is a global burden. LTBI becomes active when the immune system weakens, when the immune system is compromised. And I already found some studies about this. Could COVID-19 activate latent TB? Researchers from California, from San Diego, already start studying about this. There are not too many studies, but we found some. There are already cases, not too many cases, that demonstrate that even with mild COVID, those patients that don't even need hospitalization stimulate the reactivation of latent TB to active TB disease. And this is the case that the headline in the top right. That is a nice case report from India showing this patient that reactivate active TB disease, having latent TB and mild COVID. These are more studies about the reactivation of dormant tuberculosis due to COVID. If this effect is common, it may have a significant impact on the worldwide TB burden as well as in USA. Why in USA? Because we have to remember that up to 13 million people in US have latent TB. And remember, as yesterday, 41 million cases of COVID have been reported in US. So maybe we are going to see overlap with the COVID, patients with COVID and these patients or these people with latent TB. So more questions to ask to the researchers. 13 million people with latent TB. According with the CDC, 1 in 10 people without treatment will develop TB disease. Are you thinking in a TB search in the post-COVID era? With this pandemic, we have new factors to add to this equation. More studies are needed and more research is needed. And we are going to start seeing more studies coming up. Now I want to invite you to listen to Marybel Monreal, who will present a case, and she's going to illustrate how COVID-19 could be a factor in the developing of active TB in a patient. Welcome, Marybel.
Thank you so much, Catalina, for helping us to understand how COVID-19 may now be a risk factor for progression to TB disease. So now, keeping all that information in mind, let's all take a closer look at a case study that touches on this new emergence. Here we have a 42-year-old female originally from the Philippines who entered the U.S. in 2008. In 2021, this patient reported feeling fine until about mid to late January when she began having a cough. On the 21st of January, she tested positive for the COVID-19 virus. The following day, she started to experience shortness of breath. And on January 23rd, her symptoms became so severe that she was rushed to the hospital where she was admitted with a complicated course of COVID-19. This patient, like so many we have heard of, required intubation for an extended period of time, during which she developed bacterial infections and suffered from acute kidney injury. Almost 1 month later, on February 22nd, the patient was stable enough to be discharged home on 3 liters of oxygen. So I encourage you all to take a little time to just think about the extent of stress that this patient suffered during her extended hospital stay, both physically and emotionally. So once back at home, the patient had continued weakness and was only able to ambulate with the assistance of a walker. She had a persistent cough and shortness of breath that required the use of supplemental oxygen. It's important to remember, when symptoms persist after a COVID diagnosis, you may want to start thinking, could this possibly be TB? 7 days after her discharge, on March 1st, the patient suffered a syncopal episode and woke up in the ICU. She had a CT done that helped rule out an embolus. However, it did show extensive bilateral infiltrates, new pulmonary opacities that were not concurrent with resolving coronavirus. She also had a bronchoscopy with a BAL, which resulted negative for fungi and AFB, but pathology did show necrotizing granuloma. On March 4th, sputum cultures resulted positive for MTB with no rifampin resistance detected. The following day, the patient was discharged home on empiric treatment with levofloxacin and fluconazole. A few weeks passed, and on March 26th, the patient was seen by the local health department, where they drew a T-spot, they collected new induced sputum, and they took a thorough history on her. The patient had no known TB exposure prior to her TB diagnosis. She had last traveled to the Philippines in 2010. However, she did continue to have frequent visitors from the Philippines. She was diagnosed with type 1 diabetes in 2017 and was on treatment with metformin and insulin. At that time of the assessment, her hemoglobin A1C resulted in 10%. So the results show that the patient had a positive T-spot. Sputum from 326 and 328 were also positive, and her chest X-ray was abnormal. So on March 30th, the patient was started on RIPE for pan-susceptible bilateral pulmonary TB for 6 months. So again, let's pause just for a minute and reflect on what has occurred in this severe case of COVID-19. So what impact did the stress of COVID-19 have on the patient's body? Did this patient's complicated course of COVID-19 increase her risk of progression to active TB disease? Remember, she had a complicated course with intubation, candidemia, bacteremia, prolonged ICU care. She had high-dose steroid use, which we know causes immune suppression, malnutrition, and even organ failure. Additionally, we also need to consider underlying factors, risk factors, such as being foreign-born, having diabetes, and the possibility of LTBI, although it was uncertain given her risk factors, though we can make, that type of assumption. In TB, we know there are individuals who are at risk, increased risk for progression to TB disease, and those include individuals with HIV, persons with a history of prior or untreated TB with fibrotic lesions on a chest X-ray, children that are 5 years and younger with a positive skin test, persons that are underweight, substance users, and individuals on treatment with TNF alpha blockers for diseases such as rheumatoid arthritis or Crohn's disease. And then we'll have a category for those with certain medical conditions that increase their risk, which include individuals with diabetes, chronic kidney disease, immune suppression, organ transplant, and even a history of a GI surgery. Now, with all this new ongoing research that Catalina just talked to us about, on the example that she gave in the last case, will COVID-19 now be added to this list that we have here as a risk factor for progression to TB disease? Let's look at how COVID-19 may precipitate this progression. To the left of your screen, you will see the risk factors that we just went over. But now we should also start thinking about adding COVID-19 as a risk factor, because as we have learned throughout this presentation, COVID-19 causes a great amount of stress to the body, to include malnutrition, low protein and caloric intake, use of high-dose steroids, which can cause, again, the immune suppression and all the things that Catalina just talked to us about, the cytokine storm and the T cells, poor glucose control, and even organ failure. I want you all to just imagine being diagnosed with two stigmatizing diseases, one after the other, just like that, back to back. How do you think you would feel? What would your family, friends, and even coworkers think? Here at Heartland, we actually had the opportunity to interview the patient from this last case study that I just presented to you. We wanted to hear about her experience with COVID and TB and the impact that it had on her life. To respect the patient's privacy, we will not be sharing any personal identifiers, but instead, I invite you all to listen to her message in this brief 3-question interview.
How did you feel with your second hospitalization, and what thoughts were going through your mind?
I was scared because I have 2 sons. I have my husband and my mom living with me. In my thoughts, like TB is very, complicated. But in the help of my family, they explained to me that tuberculosis can cure. But I was scared.
How did your friends and family react when you were diagnosed with another infectious disease? And how did this make you feel?
Only my family knew about it because I don't want any rumors, or I don't want them to get scared about me too. It's been sad because my kids is with me, my husband. I cannot hug them. I cannot be closer to them. My eldest son been asking me, I thought you're already negative from COVID. Why you still in mask? I said, well, just for safety, but I didn't let him know that I was in another infection.
What would you like healthcare providers to know about your experience?
For the nurses or providers, just be patients with their patient, because I experienced some nurses too that I feel like they're getting tired of me. They're impatient, so it's very very hard. And I said, like, I don't want to be in the hospital anymore. Every nurses ignores me, and I was like, why they're ignoring me? I've been asking for food. I'm so hungry. I saw them back and forth delivering food for other patients, but they pass my room. I'm so weak, I cannot able to touch my phone, to call my husband, nothing. But I'm still lucky. I'm still lucky that I have a good nurses. So don't lose hope. I want to inspire people to that who's going through on the same situation. Just keep on fighting. Keep on fighting.
But wow, what a powerful message the patient had. She reminds us not to forget about one key role in nursing management: patient-centered care. We cannot lose sight of this because it is so important. With this new emergence, we will start seeing more physically and emotionally stressed patients. And we as healthcare providers need to remember the importance of building relationships with them and their families, just as Jeanne talked about at the beginning of our webinar. If we educate patients and include them and their families in the decision-making of their treatment plan, we can together achieve improved healthcare outcomes. But I did just want to go ahead and summarize our presentation for today. So Jeanne reminded us of the impact the coronavirus has had in the diagnosis of TB. And like Catalina mentioned, it has set the progress of TB elimination back by 12 years. It may be that we will start to see more complex patients who have had COVID-19 and developed TB disease. So as healthcare providers, we have the continued responsibility to advocate for our patients when we think TB and reach out to our infectious disease nurses, just as Jeanne did, and send referrals and even educate other healthcare providers about TB in the midst of this pandemic. I know that we have had a lot of information presented to you today, but Heartland is also working on a fact sheet to summarize some of today's key points. and also to provide guidance on COVID-19 as a risk factor for progression to TB disease. This fact sheet, it will be available in a few weeks, so please, I invite you to join our distribution list if you are not already part of it, so you can be notified once it does become available. This fact sheet is something that we want you to use in your place of practice and also to share with your healthcare team so that together we can all be aware of the new risk factors that are now in TB. I want to thank you all so much for your patience, as we do have just a few minutes left here, so we're going to take a look at some of the questions that you guys had put into our Q&A and our chat box. However, if we're not able to get to your question right now, we will respond to you via email. And if for some reason we don't, please feel free to our Heartland website. Our emails are on there, and you guys can reach us that way at any time.
So if you have any questions, can you please enter those into the Q&A pod, not the chat box, please? The speakers will be reviewing all the questions from the Q&A pod only.
We see that Leanne is asking a question. She wrote, seems that fighting and treating LTBI more important now than ever. Definitely. Yes, I think now that we have these immune problems with the COVID, I think probably the LTBI treatment should be important. And any new data on effect of COVID disease and or COVID vaccine on IGRA results. I haven't seen any studies about that. I didn't check of those, but maybe we can start looking, and if we find something, we can share with you.
Okay, so I see Dory is asking, how do we sign up to get the fact sheet? So if you visit our website, we do have a way for you to sign up to be part of our constant contact. It's a distribution list, and as soon as we finish developing that sheet, we will send out actually a notification to all our distribution lists so that you're aware that it's out and you can download it from our website. And definitely, we want you all looking at that, studying it, and sharing it with everybody in your healthcare community. Let's see. So I see Elizabeth had a question in contact investigation. Should we be prioritizing contacts who've had COVID like we do HIV positive contacts? Well, that's a great question, Elizabeth. And I'm not specialized in contact investigation, but I would assume so, because this is, again, a very important topic. And just as with TB, I mean, contact investigation is important to minimize and put a hold on, the spread and emergence of this new disease.
Yes, and this presentation just wanted to open questions to the community of researchers because there is still too much to research. So maybe that you said that we should be prioritizing contacts with COVID now, like HIV. That is a good question for maybe the researchers. They are going to start doing studies about that, and probably in 1 year we are going to see a new contact investigation risk factors, or this risk factor being for a new contact investigation guideline. So this is all open questions and open for TB elimination and everything. Is there reason to be concerned about false negative TS-pulse due to the exhaustion of T cells? I think there are studies that are showing that the immune system being shut down or being affected by the COVID. Of course, we know that if the immune system is compromised, the TS-PAD or the TST or the quantiferon gold is going to be maybe false negative. And yes.
Okay. So let me see here. It looks like we had a question about the health department, and I wanted to get that to Jeanne. Let's see.
Hi, yes, I saw the question from Ms. Juarez. How did you manage getting 24-year-old through the Border Patrol to get to the hospital? Is that the one you're referring to?
Yeah, there was a few, Jeanne, but you can answer that one.
Okay, all right. So we went through the process with Border Patrol, which is a fingerprinting and a background check. So this needs to be done prior. So of course we use all infection control protocols as far as like making sure that the individuals that are coming, the Border Patrol agents that are coming, that they do wear their N95s and everything, because usually our patients are still infectious. So when they come and meet with a patient, we let them know. Usually we kind of give a heads up, like a run through to the patient, letting them know what is usually the process. And so usually like 2 agents will come by, they'll fingerprint the patient and they'll do a background check. They'll ask them a series of questions. And then they usually go back to their facility and do the background check and conduct everything. And then usually by the following day, they give us an answer and they say that there's been clearance given. And usually what they're looking for is like anything like just, you know, really bad, like that they're just have like a bad background. We've been really successful, which is really good. We haven't had anybody that has not crossed the border going through this process. So I just want to thank all of the staff that, you know, go through the process of doing this when they do. And of course, getting the patient to follow through and just give all the information to the Border Patrol, because it is a really scary process, you guys. But we've had great success. We have also had patients that once they finish the process, they do, what we've heard is once they come back and they they're being seen here at Hidalgo County through the outpatient process, they do tend to have like a meeting with the judge later on. And then the judge will go ahead and kind of just go through them with the process. We've had some patients that have come back and they've told us, you know, sometime after when they've already completed treatment, that they had a court date and they go by and the judge sometimes allows them the process to go through and finish their process for citizenship. So we've had good success from this.
Thank you, Jeanne. We appreciate your response. So I do see we have a few more questions on here, and we're kind of running short on time. So we will go back and look at them and maybe put together a response that we could send you all. And also, I just wanted to mention, because I see on here a couple questions. So all the research articles that we used for our presentation, they are listed on our reference page. So the presentation was shared in the chat box, I believe. So once you open that, it'll be the last slide on there. But again, if you have questions, please feel free to contact myself or Catalina or anybody in our training department, and we can get you those materials. So I will go ahead and hand it off to Rashonda, and thank you all again for your participation today.
Thank you all.